Good morning. Welcome to Chapter 13, BLS Resuscitation. The principles of basic life support have been around for quite a while. They were introduced in around 1960, when specifically CPR was designed by a physician in about 1955. Specific techniques have been revised about every 5 or 6 years. They have to be changed or looked at every 5 to 6 years, and then published every 5 years, the new guidelines for resuscitation. The most recent review was conducted by the International Liaison Committee, or ILCOR. We're about to go through another revision. 2020 will be the 5th year, being the last revision was in 2015. I don't expect a whole lot will change, but it does come in 2020. All right, so non-invasive BLS is a non-invasive emergency life-saving care that is used to treat the medical community and specific conditions to include airway obstruction, respiratory arrest, and cardiac arrest. It's all focused around the ABCs, airway, breathing, and circulations. If the patient is in cardiac arrest, then the CAB sequence must be used because chest compressions are essential and must be started as quickly as possible. Only seconds should pass between the time that you recognize that the patient needs BLS and the time that you start treatment. All right, so this figure on this particular slide, it illustrates the concept that time is critical for patients who are not breathing. If the brain is deprived from oxygen for 4 to 6 minutes, brain damage is possible. In cardiopulmonary resuscitation, or what we know as CPR, it establishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. The CPR steps are as follows. Restore circulation by performing chest compressions to circulate the blood, and then also perform 30, in your performance, there'll be 30 high quality compressions, opening the airway, restore breathing, providing rescue breathing, and then administer 2 breaths while visualizing for chest rise. All right, so this slide demonstrates 2 EMS providers performing CPR. As you can see, the chest placement here, or the hands on the chest placement there, and then somebody using a BVM connected to supplemental oxygen to ventilate. All right, so BLS differs from advanced life support, ALS, which involves advanced procedures such as cardiac monitoring, assisting or administering of intravenous IV fluids and medications, and also use of advanced airway adjuncts. When done correctly, BLS can maintain life for a short time until ALS measures can be started. This is the chain of survival, recognition and activation of EMS, and then immediate high-quality CPR, rapid defibrillation, basic and advanced EMS applications, and then post-arrest ALS care. The components, or the system components of CPR, includes the chain of survival, which is established by the American Heart Association. It starts with recognition and activation of the emergency response system, and then immediately application of high-quality CPR, rapid defibrillation, basic and advanced emergency medical services, advanced life support, and post-arrest care. Any one of these links in the chain is very, very important, and if it fails, then the patient is more likely to die. Always begin by surveying the scene. It's just like we've talked about over and over again with scene safety. Complete your primary assessment as soon as possible. Determine unresponsiveness. Responsiveness or responsive patients obviously don't need CPR because they should have a pulse. Basic principles of BLS are the same for infants, children, and adults. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true for infants and children. All right, so this is a figure here, a photograph here showing a first responder that's trying to establish if the patient is unresponsive by doing the shake and shout. Hey, 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 are you okay? He's got, hands on both shoulders, and he's speaking to the individual in a loud enough tone that if he was asleep, he should wake up. All right, so defibrillation, automatic defibrillation is a vital link of the chain of survival. Anybody can use an AED. An automatic external defibrillator should be applied to patients that are in cardiac arrest as soon as it's possible. If you witness cardiac arrest, begin CPR and apply the AED as soon as it's available. Okay, so AED in children, apply after the first 5 cycles. Do 5 cycles of CPR and then go ahead and apply it to a child. Manual defibrillator is preferred for infants 1 month to 1 year. If unavailable, you can use pediatric-sized pads and a dose attenuating system. If neither is available, then an AED with an adult-sized pads with anterior and posterior placement can be used. Special situation, pacemakers. Pacemakers should be on the left side of the chest. If they are on the right side of the chest, just make sure that you don't put the pads on top of the pacemaker. For wet patients, just dry them off thoroughly. You can still apply the pads if they're still wet, but you can just dry them off the best you can. And then of course, transdermal medications. If there's some kind of patch on the chest, go ahead and pull the patch off and then wipe it with a towel or something to get the medication off, so there won't be any chance that the pad that you're going to apply where it was at won't stick. All right, so positioning the patient. For CPR to be effective, the patient must be supine on a firm, flat surface. There must be enough space for 2 rescuers to perform CPR. Log roll the patient, if necessary, onto a backboard because it's hard. You can do CPR on it, and you can transport the patient when you're ready. All right, so checking for a pulse, as you can see here, 3 fingers. Feeling for the carotid pulse that should be in the neck, and also you're going to be scanning the body. So you're going to go, hey, 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 are you okay? Help, help! Somebody get 911 and call 911 and get an AED. Then you're going to check for a pulse, and you're going to scan the body looking for any signs of breathing. You will do this for no more than 10 seconds, but no less than 5 seconds. So you're going to feel between 5 to 10 seconds to see if there's a pulse. All right, so if there is no pulse, you're going to provide external chest compressions. Apply a rhythmic pressure and relaxation to the lower half of the sternum. You're compressing and squeezing the heart. It's acting as an artificial pump to circulate the blood that's in there. Avoid leaning on the chest in between compressions. Proper hand position is crucial for this procedure. Injuries can be minimized by properly utilizing the hand placement in the proper place and onto the sternum. So you need to make sure that you do that correctly. All right, so this is a representation, this diagram. It shows the slide. The slide illustrates where the heart lies slightly to the left of the middle of the chest and between the human spine. You're compressing it between the spine and the breastbone. You can see here the sternum has been removed, so you can see this. But the sternum goes over top of this, and that's what you're compressing down on the heart to make it work. All right, so this figure shows the compression and relaxation. You need to push completely down and then recoil completely up. So you squeeze the heart, okay, and it pushes the blood out, and then you relax the heart, which allows for the blood to return or suck back into the heart. So that's how you're completing the cycle of artificial compression. All right, this shows the opening the airway. This is your head tilt chin lift maneuver like we talked in the airway lecture, and this is the jaw thrust maneuver if the patient is suspected of a cervical spine injury. If you determine that the patient is adequately breathing, but there's no sign of injury to the head or spine or pelvis, you can place the patient into the recovery position. That's laying on their side, left lateral recumbent, with the knee slightly flexed. Okay, this keeps the patient from rolling back over. And like I said earlier in the airway position or in the airway lecture, you can see that the arm is slightly bent at the elbow and the hand is underneath the face. This will allow them to keep their face off the concrete and then also allow them to maintain their airway. And if they do vomit, they'll be on their side. They won't aspirate it. The combination of lack of oxygen and too much carbon dioxide in the blood is lethal. We talked about that in airway. So if you have a patient that you need to provide breaths for, you're going to provide slow, deliberate ventilations that last at least 1 second. If the patient is not breathing, ventilations can be done by 1 or 2 EMS providers, utilizing a barrier device such as a mask with a valve on it. This is your BVM. We talked about this in airway. So make sure that you've got the EC technique. Okay, here's the 3 fingers that form the E. Here's the C clamp that is on the mask, and then one hand of the squeeze of the bag. For a patient with a stoma, place a BVM or pocket mask directly over the stoma. Artificial ventilations may also result in gastric distension, so be prepared for the patient to vomit, and if you need to, roll them on the side and make sure that you have suction available to be able to clear the airway and also get the gastric distension out. All right, so this is to a stoma. This is the stoma here, little hole, okay? And this is using an infant-sized mask to put over the stoma to make a seal to be able to ventilate. Single rescuer gives both chest compressions and artificial ventilations of a ratio of compression to ventilations of 30 to 2 when you're by yourself. So this is 1 rescuer adult CPR. 2 rescuer CPR. It is always preferable to 1 rescuer CPR overall. Rescuers doing compressions can be switched. Switching rescuers during CPR is critical to maintain high quality compressions. It's recommended to switch every 2-minute cycles. So after the 2 minutes, the person that's doing compressions will then switch to do ventilations. Devices and techniques to assist circulations: active compression, decompression CPR, impedance threshold devices, mechanical piston devices, load distributing bands, manual chest compression still remain the absolute standard of care. So there's telling us that there's a lot of different mechanical devices that you can use to assist with your CPR. All right, so this is one device, a manual device, okay, where you can see that this gentleman is holding the device and pushing down and doing compressions. This is the T-pod device. It will help with doing compressions because it creates a suction application to the airway while you're actually doing ventilations. So therefore, it's allowing for full recoil of the heart. Cardiac arrest in infants and children follows respiratory arrest. Airway and breathing are the focus of pediatric BLS. Usually, it's anytime an infant or a child's in cardiac arrest, it's because of a respiratory problem initial. Determine the unresponsiveness of the child. Gently tap on the shoulder, speak loudly, say, hey, are you okay? Check for breathing and a pulse. And this assessment should occur simultaneously. It should take no longer than 10 seconds. Foreign body obstruction is very, very common in children. They're always running around eating their hot dogs at the same time when they should be sitting. Place unresponsive breathing child to the recovery position if you have to leave them, just like with the adults, to go get 911. But you're going to do a round of CPR first because you may resolve their problem. The techniques for opening the airway are modified for pediatric patients. You need to place a wedge under the upper chest and shoulders when supine. That'll help to hold the airway open. Providing rescue breathing. If the patient's not breathing and has a pulse, it's 1 breath every 3 to 5 seconds for the child or infant. Don't forget, for the adult, it's 1 breath every 5 to 6 seconds. If they're not breathing and have no pulse, then you're going to give 2 breaths after every 30 compressions. So when you're by yourself, it's 30 compressions, 2 ventilations for everybody. Doesn't matter whether it's an adult, doesn't matter whether it's a child or an infant. When you're by yourself, single rescuer is what we call that. It's 30 to 2. Now, if it's an infant or a child and you have 2 rescuers, it's 15 to 2. CPR is crucial. It's a life-saving procedure. It provides minimal circulation and ventilation until the patient can receive defibrillation, ALS treatment, and also definitive care. If no ALS is available at the scene, provide transport for local protocols, and then consider requesting an ALS rendezvous on your way to the hospital if you can meet up with them before you get there. Interrupting CPR. Try not to interrupt CPR for no more than just a few seconds. Chest compression fraction ratios are very, very important. It is the total percentage of time during a resuscitation attempt in which the chest compressions are being performed. It should be at least 6% in accuracy. If the scene is not safe, that's when you're not going to start CPR. If the patient has obvious signs of death or if the patient and a physician had previously agreed to a do not resuscitate order. Okay. When to stop CPR. Once you begin CPR, continue until the stop acronym, anything falls in place. 1, the patient starts breathing and has a pulse. 2, T, patient is transferred to another provider of equal or higher level training. O, you are out of strength and just cannot go on. And then P, a physician directs you to discontinue. Out of strength does not mean that you're just unable to continue. You're physically exhausted, that you just cannot carry on. All right, so foreign body airway obstruction in adults. Usually a cause of an airway obstruction is usually something that they've eaten. It's usually a big piece of meat, something like that. For adults, it usually occurs during a meal. In children, it usually occurs during a meal or at play, either one. Or sometimes you may have a patient with a mild airway obstruction. They're able to exchange air, but they have signs of respiratory distress. You want to encourage them to cough. Sudden severe obstruction is usually easy to recognize in the responsive patients. They do the universal choking sign. In unresponsive patients, suspect obstruction if maneuvers to open the airway and ventilate are ineffective. The abdominal thrust maneuver, or the Heimlich maneuver, is recommended in responsive adults and children older than 1 year. For obstruction, again, instead of abdominal thrust maneuver, use chest thrust for the following responsive patients: women in advanced stages of pregnancy, and also obese patients, because you just can't reach all the way around these folks. Here's an example where you're doing chest thrusts in a pregnant woman, because you're up above her breast, and so that you can get right in the middle of the chest, and you're still trying to force air through the chest cavity, up through the trachea to displace whatever it is that's in the back of her throat. All right, so unresponsive patients, determine unresponsiveness, check for breathing and a pulse. If a pulse is present and breathing is absent, attempt ventilation. If 2 attempts do not produce visible chest rise, perform 30 compressions, open an airway, and look in the mouth. Attempt to carefully remove any visible object that may be in the mouth. All right, so foreign body obstruction in infants and children. Airway obstruction is the common problem in infants and children. In patients who have signs and symptoms of airway infection, do not waste time to try to dislodge a foreign body. It's usually related to the infection. Administer supplemental oxygen if needed, and immediately transport the child to the emergency department. As long as the patient can breathe, cough, or talk, do not interfere with his or her attempts to expel any foreign body airway. Administer supplemental oxygen if needed and tolerated and provide transport to the emergency department. On a responsive standing or sitting child, perform the Heimlich maneuver, but with less force than what would be used the same way with an adult. An unresponsive child older than 1 year who has an airway obstruction is managed in the same manner as adult. We'll do that in skill drill 13-6. All right, so here you go. This is an example of a child in standing position, and you're going to perform the abdominal thrust. In infants, perform back slaps and chest thrusts. Those chest thrusts are the same as just the compressions. You're going to flip that child over and over again until it comes out, usually with the back slaps and the head down into a lower position. Whatever the object is, that's when it falls out. Here you go. There's your back slaps, and then there's your chest thrust. You're just flipping them back and forth until you can get the object out. Make sure that you support them. Don't drop them. That's going to be even worse. But anyhow, back slaps ×5, chest thrust ×5 until it comes out. In unresponsive infants, begin CPR just the same, beginning with chest compressions. Do not check for a pulse before starting the compressions. Go ahead and do it to get whatever the object out, because our goal is to get the foreign body out. Open the airway and look inside the mouth. If you see an object that can easily be removed, then remove it with your finger and attempt to ventilate. If you do not see it, Then resume chest compressions. Continue that sequence of chest compressions and opening the airway and looking inside the mouth until the obstruction is relieved or ALS providers take over. Special circumstances. We have a lot of opioid overdoses nowadays, so if you have it, if naloxone was administered by a bystander prior to your arrival, then determine how much of the medication was given by what route it was given. The recommended algorithm for implementing naloxone into a cardiac arrest management sequence is discussed in Chapter 21, Toxicology. We'll go over it then. Standard resuscitation measures take priority over naloxone administration. When you have cardiac arrest in pregnancy, that's another special circumstance. Priorities are to provide high-quality CPR and relieve pressure off the aorta and vena cava. If the pregnant patient is not in cardiac arrest, then position her on her left side to relieve pressure on the great vessel. That prevents supine hypotension syndrome. If she is in cardiac arrest and the top of the patient's uterus can be felt at or above, you're going to go ahead and perform CPR as normal. All right, so grief, for the bystanders and also loved ones, family members may experience psychological crisis that turns into a medical crisis. You may end up with more patients. Your patient may initially be the person you're doing cardiac arrest on, you're doing CPR on, but then it may change the family members and also the loved ones. Keep the family informed throughout the resuscitation process. There's nothing worse than lack of communication with family members. They will remember that portion of it, as well as the crisis itself of their loved one being in cardiac arrest. After resuscitation is stopped, helpful measures include take the family to a quiet place, use clear language, and speak with a warm, sensitive, caring manner. Exhibit calm, reasserting authority, but yet, still using the patient's name. And use eye contact as well, and appropriate touch to relieve and to calm them as best you can. Like I said, you're going to end up with patients that you're going to need from a psychological event type of manner to discuss with them and to help them through the beginnings of their grieving process. Okay, so continued as well. Expect a lot of emotion in the room. Be supportive, but don't hover over people. Ask if a friend or family member can be called, or their local pastor, somebody that can come and be with the family during this rough time. Ensure that children also are not ignored. They seem to go find little corners, but they may not understand, but make sure that somebody's with them. All right, so education period about the EMT with regards to caring, CPR skills can deteriorate over time. So you have to practice this. Practice often using a mannequin-based training, CPR self-instruction through a video and or computer-based models with hands-on practice also can be a reasonable alternative to instructor-led programs. For the public, you're a patient advocate. You must do your part to facilitate the training of lay people and critical skills of CPR and AED operation. All right, so with this, that's the end of the lecture. Go ahead and do the review on your own. And thank you for attending this lecture, and we'll see you next time.